Good evening, ladies and gentlemen. First, I would like to thank you all for joining this webinar on behalf of the Colombo North Center for Liver Disease. Today, we are going to talk about a topic which is not very often discussed in these webinars, taking care of patients with compensated chronic advanced liver disease or compensated cirrhosis. Cirrhosis is predicted to become one of the most common causes of death in the productive age group in the future. Within the next 10 years, it's predicted to be one of the most common causes of death in line with ischemic heart disease, stroke, and malignancies. It is equally important as ischemic heart disease, stroke, or diabetes, but has not received the same attention so far. It is not adequately represented in any of the non-communicable disease preventive programs anywhere in the world. Major advances in the management of which could delay decompensation and death are there, but unfortunately, those are not common knowledge. To initiate these interventions, cirrhosis should be diagnosed as early as possible. So what is decompensated cirrhosis? So to discuss compensated cirrhosis, we should know what is decompensated cirrhosis. So decompensated cirrhosis is cirrhosis with past or present ascites, encephalopathy, or upper GI bleeding. But if they present with any of these features of decompensation, then life expectancy without a transplant is very limited. So unfortunately, anywhere in the world, even in the United States, most of the patients with cirrhosis present with an episode of decompensation because compensated cirrhosis is asymptomatic. So then what is compensated cirrhosis? Compensated cirrhosis is cirrhosis without ascites, encephalopathy, or variceal bleeding. And they are asymptomatic and they are usually diagnosed accidentally. So then what is compensated advanced chronic liver disease? It's somewhat similar to the compensated cirrhosis, but includes some patients with advanced fibrosis detected by fibroscan or vibration controlled transient elastography, which measures the liver stiffness in kilopascals. And there is a example that I have given with the fibroscan. We can say whether there is advanced fibrosis or not. So this is a fibroscan examination. Is somewhat similar to ultrasound scan with a machine and a screen and a probe. You just need 2 hours fasting to do it. And after that, you get a report with 2 figures, one in blue and one in yellow. So I'm concerned with the number in yellow here. The left-hand side, liver stiffness is 3.5 kilopascals, and the right-hand side report, the liver stiffness is 33.3 kilopascals. This is how it corresponds to the liver stiffness. In a normal liver stiffness is generally less than 7. So it's 3.5. The patient has a normal liver. A cirrhotic liver will have a stiffness of more than 15, 20, 25. And here 33.3 represents a cirrhotic liver. So when if at birth, if you measure the liver stiffness, it's very low. It's around 2.5. With age and various salts like infiltration in 7 scan. This is the same measurement macroscopically. This is a normal liver. Then you get a fatty liver. This is decompensated cirrhosis. If you start your fat infiltration around the age of 20 due to various reasons, each step will take another 7 to 10 years. And usually these patients present around the age of 50 with an event of decompensation event like variceal bleeding or ascites or encephalopathy. So I'm going to concentrate on stage 3 and 4 according to this diagram, that is compensated advanced fibrosis and compensated cirrhosis, because we have a window of opportunity for about 10-15 years to treat them and manage them and intervene and make sure that the progression to decompensation is delayed significantly. So why should we take care of the patients with compensated cirrhosis very carefully? Because transplantation is not an option for most patients with cirrhosis. I will tell you why. Transplantation is not an option for all patients with cirrhosis because of the cost, the organ shortage, and the lack of expertise, and the candidate issues like kidney failure, ischemic heart disease, age, and other comorbidities. Even in developed countries, less than 25% of patients with decompensated cirrhosis will receive a liver transplant. Because we have a window of opportunity to delay decompensation and death by interventions, we should concentrate on that. For this, we need to diagnose cirrhosis as early as possible. So how to diagnose cirrhosis early? So up to now, we didn't have any recommended screening programs to diagnose cirrhosis, but of late, we have been getting various guidelines on how to diagnose cirrhosis, advanced fibrosis and cirrhosis early. One is there are clear guidelines for diabetics now to have screening for advanced liver disease. There are clear guidelines for patients with fatty liver to catch patients with advanced fibrosis and cirrhosis. And in other patients, you should have high index of suspicion. For example, if you see a patient with alcohol use disorder, you should keep an eye on the liver because they are candidates for liver cirrhosis. And in patients with family history of cirrhosis and hepatocellular carcinoma, again, you can look at their livers to see whether there is any hint of fibrosis in them. And sometimes liver cirrhosis is accidentally diagnosed by surgeons by direct vision during surgery for other illnesses, by hematologists when they investigate thrombocytopenia, by radiologists when they do the scans for any other illnesses, and sometimes at regular annual medical checkup programs sponsored by various companies. So I'm going to discuss three patients today and discuss them with you. This patient I have presented many times now, but such a valuable example of what I'm going to tell you today, I'm going to present it again. This is a 52-year-old male doctor who accidentally detected to have a macroscopic cirrhosis, so gallbladder calculi. He underwent a laparoscopic cholecystectomy, and the surgeons saw the liver, which had features of macroscopic features of cirrhosis. He was asymptomatic, totally asymptomatic, had none of the symptoms attributed to cirrhosis. He had mild elevations of transaminases in the past. He attributed it to fatty liver, but didn't have any symptoms attributed to cirrhosis. Workup for etiology didn't show positive findings, and he was confirmed to have compensated cirrhosis. His mother had died of cryptogenic cirrhosis at the age of 65. So naturally, being a doctor known to me, he had few questions posted to me after his diagnosis when he came to meet me. These were his questions. How long I am going to live? When will I need a liver transplant? Obviously, he knew that he will never need a liver transplant one day. How can I be a suitable candidate for transplant? Is there any drug or any other measure to delay progression? My mother had it. Will my daughter get it? Very good question. Can we prevent cirrhosis in my child? That was more important to him than his own life. So if you diagnose compensated, what is next? Stage according to the severity of portal hypertension. Why? If there's clinically significant portal hypertension, they are benefited by non-selective beta blockers like carvedilol. So carvedilol is one drug that is going to delay decompensation in these people. So what is clinically significant portal hypertension? The development of portal hypertension increases the risk of decompensation and death. Obviously, compensated cirrhosis can be divided into cirrhosis without clinically significant portal hypertension and cirrhosis, decompensated cirrhosis without portal hypertension and compensated cirrhosis with clinically significant portal hypertension. When they develop clinically significant portal hypertension, obviously there are chances of decompensation and death is raised. So now, second point that I'm going to emphasize today, now we can reliably predict portal hypertension without an endoscopy by the platelet count and by doing a fibroscan. So if the liver stiffness is more than 25, we can consider that the patient has clinically significant portal hypertension, and the stiffness is between 20 and 25 with a platelet count of less than 150,000. Again, we can predict clinically significant portal hypertension, and with a lower stiffness of 50 to 20 with a platelet count of less than 110, again, we can predict. So with the liver stiffness and the platelet count, see how important the platelet count is. Platelet count is part of the FIB4 score that I have discussed with you many times earlier. So this was the older classification when we did a endoscopy to see. Still, obviously, you can do an endoscopy, but because the invention of the fibroscan and the various methods of predicting portal hypertension, now we can do it without endoscopy. So if we still don't have a fibroscan, we can still do endoscopy, and if there are no varices, again, it's stage 1, and if there are varices, it is stage 2. So roughly, what's the life expectancy? I think as doctors, we should know about this if we are dealing with cirrhosis. Child's A, no clinically significant portal hypertension. The patient is expected to live 10, 15, and even 20 years with interventions. The moment they become decompensated, they develop ascites, the prognosis, the life expectancy drops drastically to about around 3 to 5 years. And if they are on regular paracentesis for ascites, it's only going to be only a few months without a transplant. So in between, can these patients die unexpectedly? Yes, that's the whole basis of looking after these patients, detecting them early and intervening with various measures. One is liver cancer. From the patient with advanced fibrosis onwards up to decompensated cirrhosis, they have a very high risk of hepatocellular carcinoma. So if these patients are asymptomatic, they will develop a hepatocellular carcinoma. Then they become symptomatic. When they start palpating the tumor, only they will present. So diagnose these patients early and to screen them every 6 months for do a surveillance ultrasound scan and alpha fetoprotein to detect a small hepatocellular carcinoma so that we can remove that very easily. So then acute on chronic liver failure. In between, these patients can develop any other assault on the liver, like any other person. So can develop hepatitis A, hepatitis B, dengue, drug-induced liver disease, and if he drinks further, he will develop alcoholic hepatitis. And this liver, which has cirrhosis, but just asymptomatic, will not tolerate this kind of assault. So all the preventive measures to avoid something like that should be in place. And at the same time, especially patients with NASH cirrhosis are at risk of unrelated uh, uh, cause of death like myocardial infarction. So if you are dealing with these patients, especially NASH cirrhosis, you should be looking into their other comorbid factors also, and we have to address the other factors at the same time. So, $1 million question today: can we delay progression? Yes, we can, and this should be our objective, right? So, this new concept of delaying decompensation was first discussed by this great famous hepatologist, British hepatologist from Royal Free London. Unfortunately, just after publication of this paper, he passed away. I quote, this is what he wrote in the Lancet in 2014. I quote, the new concept in management of patients with cirrhosis should be prevention and early intervention to stabilize disease progression and to avoid and delay clinical decompensation and the need for liver transplantation. The challenge in the 21st century is to prevent the need for liver transplantation in as many patients with cirrhosis as possible. So I unquote. Now, he being a famous transplant hepatologist also thought that transplantation is not going to be the solution for all patients with cirrhosis. So I'm going to present my second patient now, a 55-year-old asymptomatic, again, man developed fever with rising liver enzymes from the onset of fever, with AST peaking around 5,000 and ALT peaking around 1,800 of day 5. He was dengue antigen positive. AST ALT started recovering, but the bilirubin and INR started rising further, and the bilirubin reached 25 milligrams and INR 2.4 on day 16. This is liver failure. Ultrasound scan showed established cirrhosis with ascites. He developed encephalopathy on day 90 and succumbed to his illness on day 22 while receiving transplantation. So here, perfectly well, seemingly perfectly well, patient developing dengue and developing dengue hepatitis and dying of acute on chronic liver failure after 22 days. I must tell you that there will be a lot of patients going around in the society with asymptomatic compensated cirrhosis. So if they by chance get something like dengue or hepatitis A or even a drug-induced liver disease, they will not do as well as the people with normal livers. So acute on chronic liver failure is acute hepatic decompensation in patients with compensated cirrhosis. And these are the culprits like viral hepatitis, drug-induced liver disease, infections, and it's a syndrome with systemic inflammation and organ failure. So how can we delay progression of compensated cirrhosis? So there are very specific measures and some general measures to make sure they remain well compensated for a longer period of time. So what are the specific measures that have been shown to be beneficial? Treat the underlying cause. It's the most important treatment option. Treat or removal of or suppression of the primary etiological factor. Then Secondly, surveillance for hepatocellular carcinoma. Vaccination for infections that is possible, like hepatitis A, B, and I must tell you that more than 50% of our patients with cirrhosis are non-immune for hepatitis A. So we have improving hygienic standards in the country, and hepatitis A is not very common like it was 20, 30 years ago. So there are a lot of people who are non-immune for hepatitis A, and if a cirrhotic gets hepatitis A, he is not going to survive. So check them for hepatitis A and B, start vaccinating them. And varicose surveillance for clinically significant portal hypertension and start them on carvedilol therapy. And there are some medications we can think of to delay progression. So removal or suppression of primary etiological factor that I told you, which is number one in our armamentarium to deal with these patients. Treat, if they have hepatitis B, you treat hepatitis B like that, treat hepatitis C, autoimmune hepatitis with steroids, Wilson's disease, penicillamine, hemochromatosis with venesection and chelators, then ethanol liver, induced liver disease. Stop them drinking. I mean, if you stop them drinking, they do wonderfully well for the rest of their lives. So alcohol stoppage is high on the cards if you are dealing with the patients with alcoholic liver disease and compensated cirrhosis. For NAFLD, what we can do quite a few things like treating diabetes very well, treat hyperlipidemia, manage their obesity, and lifestyle modifications like exercise, avoiding fast food, avoiding fructose containing drinks, and so on. Any drug, we don't have evidence for use of vitamin E or beta-cholic acid that we use in patients with NASH, but there are quite a few studies ongoing so that we can get an answer in the future whether these drugs are beneficial in delaying decompensation in patients with compensated cirrhosis due to non-alcoholic fatty liver disease. Immunizations, hepatitis A, I told you, then B, COVID, pneumococcal, and avoiding high-risk medication. That's one of the main objectives in preventing these patients or in, falling into trouble. One is NSAIDs. We quite often see NSAIDs being used in these patients. So I think all medical students and junior doctors should realize that how bad NSAID is for not only for patients with compensated cirrhosis, even for patients with CKD, chronic kidney disease. One tablet is enough to kill them. So avoid non-steroidal anti-inflammatory drugs in these patients. Avoid drugs like methotrexate. Avoid coamoxiclav if possible. Anti-TB drugs can go for liver-friendly drugs. Things like chlorpromazine and no herbs, because we see a lot of herbal preparations are circulating for patients with fatty liver and cirrhosis. And I must tell you that there is absolutely no evidence for herbal medicine used in these patients with either compensated or decompensated liver disease. So what are the general measures beneficial? Losing weight, avoiding alcohol and smoking, even in patients who do not have alcoholic liver disease, avoiding alcohol is beneficial. Smoking increases the risk of fibrosis, and all smokers should stop smoking. Coffee intake is known to be beneficial in patients with cirrhosis and even patients with fatty liver disease. So we should encourage them to take more coffee. Nutrition, I'm going to discuss in detail, and you have to get a nutritionist involved in these patients. And exercise, I will discuss it further. Right, abstinence of alcohol and quitting smoking and drinking coffee. So there is enough evidence to encourage. This is Hepatology, one of the best liver journals recommending coffee in patients with liver fibrosis and cirrhosis few years ago. So then nutrition and how nutrition affects the skeletal muscle mass, sarcopenia. Cirrhosis patients have a hypercatabolic state with loss of muscle mass even when compensated. So even compensated patients will have gradually declining skeletal muscle mass, which is associated with poor quality of life. They can't get up and go late, mortality, and poor outcome following liver transplantation. This is how you measure skeletal muscle mass. All patients with cirrhosis are recommended to have a CT. Anyway, we'll be doing a CT at the beginning. At the same time, we should be checking the muscle mass, which should help us to take start interventions in these patients if the muscle mass is low. So there are so many reasons for them to have muscle mass, including loss of appetite, early satiety, physical inactivity, alterations in taste, anorexia. So many causes for sarcopenia, and it's becoming a very big topic in cirrhosis, and people are trying to work out what we can do to prevent it or alter it. So possible interventions include good quality nutrition and physical activity. So a late night snack to prevent long hours fasting. A normal person can go on fasting for 48 to 72 hours without breaking down their muscle. But cirrhotics, even compensated cirrhotics, will start breaking down muscle if they are fasting for more than even after overnight fast. So a late night snack will prevent breakdown of muscle. So then not just walking, muscle strengthening exercises will be needed. So patients with compensated cirrhosis should have some good quality exercise, some good quality proteins, and other replacement of nutritional micronutrients and vitamins. So exercise in cirrhosis, a big topic again, and there are guidelines on nutrition, and if you have any free time, please go through them in detail. I don't have time to discuss everything. So I just summarized the European Liver Association guidelines on compensated cirrhosis and nutrition. 20% of patients with compensated cirrhosis have nutritional deficiency. So I'm sure we Sri Lankans, this is probably for Europeans, and we may be having more, even in compensated cirrhosis. So either you do vitamin D level or zinc level or whatever, you should be able to. But if you suspect without doing the levels, again, there's scope for treatment. Nutrition assessment by a nutritionist. So we should have nutritionists who are very capable of detecting these nutritional deficiencies in patients with compensated cirrhosis. And after assessment, the CT, we can start intervening. Any food except alcohol is permitted. They can eat anything except alcohol, and 35 kilocalories per kilogram diet for calories, and 1 point normal proteins, 1.5 grams per kilogram protein. That is normal protein. It's a big change from what we preached 20 years ago. If obese, 10% weight loss recommended with 500 to 800 kilocalorie deficit while maintaining protein intake. So if the patient is obese, it's a must to reduce at least 10% of weight, so that benefit of weight reduction is going to help the patient in the long term. Then vitamin deficiencies, especially vitamin D and micronutrients like zinc, vitamin A, should be supplemented, especially if we have ways of ways. Vitamin D level is absolutely expensive, but if you suspect vitamin D deficiency, you can start them on vitamin D replacement. Any pharmacological treatment with survival benefits, that quite a lot. So it's a major paradigm shift. What we preached 10 years ago. 10 years ago, if we asked them to give statins, metformin, aspirin, then the final year student would have failed the exam. But now things have changed so much. These drugs, which have been beneficial in ischemic heart disease, now coming to liver and A lot of people think it's the same illness that is affecting these different organs. So statins, observational studies, animal studies, and even small randomized controlled trials all talk about the benefit of statins. So many pleiotropic effects of statins, like reducing inflammation, reducing fibrosis, dealing with endothelial dysfunction, reducing oxidative stress, and these are all beneficial in cirrhosis. And the Journal of Hepatology, number one journal in the field of liver, spoke about statins, all drug as new therapy for liver disease. And if I'm going to start any new drug on a patient with liver disease, is going to be a statin, because so many effects like anti-inflammatory, anti-angiogenic, anti-fibrotic, and disease. We can't recommend statins in people without a current indication for statins. But in our patients, the most of them being diabetics, now we can start statins if they are older than 40, because the diabetes guidelines say to start a statin if the patient is more than. So we can start most of our patients with compensated cirrhosis on statins based on that recommendation. And simvastatin and atorvastatin are preferred over rosuvastatin because they are water soluble, and most of the studies have used simvastatin as the drug which they have uh, uh, got positive results. So then carvedilol is beneficial in preventing decompensation in patients with clinically significant portal hypertension. It's more effective in reducing portal pressure, and it has greater benefit and better tolerated than propranolol. So carvedilol is the drug of choice. Carvedilol now can be started without an endoscopy, according to these uh, uh, numbers given by the Babino 7. This is a latest classification, a latest consensus statement given by the this group dealing with portal hypertension. Metformin has been shown if a diabetic patient develops compensated cirrhosis, then please continue metformin without a hesitation. And all these drugs, you can think about them when the patient and other complications, then you can think of whether you are going to continue with them or withholding them. But we have, as I told you, we have a 10-15 year window period to start all these drugs and see whether patient benefits in the long term. So continue metformin in patients with diabetes who have compensated cirrhosis. Again, same with ACE inhibitors and angiotensin receptor blockers. You know that they have anti-fibrotic effect, and that's why we are using them in heart disease. So they appear beneficial, and if they have hypertension, please start angiotensin converting enzyme inhibitor or angiotensin receptor blocker rather than starting any other drug. And you have to stop them when they decompensate and develop ascites. Same with aspirin. Surprisingly, even you have issues in the stomach mucosa, the risk of bleeding, the evidence is that it's beneficial in NASH and beneficially compensated cirrhosis. Again, the recommendation is that if someone has ischemic heart disease or any other indication for use of aspirin, please continue aspirin when they are compensated. Rifaximin, antibiotic used in hepatic encephalopathy. This is not recommended for compensated cirrhosis. And again, we don't have to use lactulose in compensated cirrhosis. We don't have to use diuretics like spironolactone in compensated cirrhosis because they have no ascites, no ankle edema. We don't have to use drugs like omeprazole routinely in these patients if there is no indication. So finally, my third patient that I'm going to deal today is a 55-year-old man followed up by a clinician for type 2 diabetes for many years, complained of loss of weight for 6 months. The clinician attributed it to drugs, metformin. The patient had a family history of cirrhosis. The patient's siblings, including two medical consultants, wanted a second opinion, and he was diagnosed to have an inoperable liver cancer and succumbed to his illness 2 months ago. So this is another patient that I discuss very often because of the clinical significance of this case, which happened about 5 years ago. Now, good thing is that if we follow the current guidelines in diabetes, current guidelines in fatty liver, we wouldn't have missed this case. So at least we should be happy that the guidelines are in place to detect this type of patients without waiting till they present with inoperable liver cancer, because he was totally asymptomatic till the presentation. I can't say totally because he had a loss of appetite, but it was not strong enough evidence for the clinician to suspect liver cancer because the patient didn't have any features of cirrhosis at the time of presentation. So why identify liver cancer early because and fairly easily. So a little bit of liver cancer for the junior doctors who are listening and medical students if they are listening. Liver cancer or hepatocellular carcinoma or hepatoma occurs in the background of cirrhosis. You rarely see a hepatocellular carcinoma in a non-cirrhotic liver, and very treatable if they are very small, less than 5 centimeters. And surveillance is the key. So you diagnose the patients with compensated cirrhosis and scan them every 6 months with ultrasound and serum alpha-fetoproteins. Treatment options and prognosis depend on the stage of liver functions. And if the patient is very well compensated, we have enough options. But if when they are decompensated and have ascites and portal hypertension, then we have very little options other than a transplantation. And they are diagnosed not by biopsy, they are diagnosed by imaging with a contrast enhanced CT or a contrast enhanced MRI. This is an arterial phase MRI, sorry, CT, and this is a tumor, it's a venous phase. You can clearly see the difference, and this is good enough to diagnose hepatocellular carcinoma in a cirrhotic liver. Right, to whom to refer? The medical gastroenterologist. He will go through the liver functions and stage it and get hold of a hepatobiliary surgeon and a interventional radiologist for intervention of the hepatocellular carcinoma. So when do you refer liver patients to liver transplantation? When they decompensate, upper GI bleeding, episode of encephalopathy, when they have diuretic resistant ascites or a liver cancer or high MELD score. MELD score is something calculated by using the creatinine, bilirubin, and the INR. If the MELD is high, then again it's an indication for transplant. And if you are referring for transplant, the patient should be referred early, because when the results are much better when the patient is transplanted, when he is in good health rather than decompensated and moribund. Right, okay, going back to my patient that I discussed at the beginning, the doctor who was diagnosed to have compensated cirrhosis at laparoscopy. So how to manage him? Surveillance for hepatocellular carcinoma, ultrasound scan, and alpha-feto every 6 months. Look for clinically significant portal hypertension and start him on carvedilol. Vaccinations of hepatitis E and hepatitis A and B, avoid hepatitis E risk. If we move out of Sri Lanka to our neighbors, hepatitis E risk is huge. So if you are going on pilgrimage to our neighboring country, please avoid taking food from non-hygienic places because hepatitis E risk is huge in that country. Metformin if diabetic, statin if hyperlipidemic, and if there are indications. The lifestyle modification looks like NASH cirrhosis, so avoiding fast food, avoiding fructose containing drinks, good physical activity, correct BMI, taking coffee, avoiding smoking if smoking, avoiding alcohol if taking alcohol, nutrition, zinc replacement, vitamin D replacement. Those are well accepted interventions. Manage cardiovascular risk. This is probably NASH cirrhosis. So they have very high cardiovascular risk. In fact, the commonest cause of death in these people is myocardial infarction. So no indication for diuretics, no indication for proton pump inhibitors, no indication for lactulose at this stage. Being a patient with NASH cirrhosis, we have to look after the coronaries and kidneys for the transplant. So we have to, otherwise, if he has a bad heart or bad kidneys, transplantation is not going to work. So answers to the questions that he posted to me, how long I am going to live, 10 to 15 years. And I must tell you that after 5 years, he is still very well. When will I need a transplant? How can I be a suitable transplant candidate? 10 to 15 years, attend to CV risk factors. Keep your heart going for the transplant. If there are any drugs or other measures to delay progression, yes, I have told you already. Will my child get it? Very likely. His mother had it, he had it. So very likely that child gets it. So initiate preventive measures in the child, lifestyle modification from now itself. Less fructose containing drinks, less fast foods, correct BMI and so on. Can we prevent cirrhosis in the child? Probably, because there are more than 100 randomized control trials ongoing for a treatment in non-alcoholic steatohepatitis. So transplantation reserved for patients who deserve it the most. Young people, children, acute liver failure, all these are success stories. To summarize, ladies and gentlemen, compensated cirrhosis should be diagnosed as early as possible. If detected early, decompensation of cirrhosis could be effectively delayed by interventions. Removal of the etiology is the most important intervention. Hepatocellular carcinoma surveillance, early detection of clinically significant portal hypertension, and immunizations are crucial. No recommended pharmacological intervention available for reversal of fibrosis as yet, but statin appears to be most promising. Correct nutritional interventions and exercise regimes are very beneficial, especially preventing sarcopenia. Taking care of the other coexisting illnesses should lead to better life expectancy and make the patient suitable transplant candidates. Thank you very much for your patient hearing.